Hi everyone, we're going to be doing a quick CREOG review on cervical cancer in pregnancy. In terms of our learning objectives, we are going to be reviewing the epidemiology of cervical cancer as well as its prevalence in pregnancy. We will be describing the risk factors associated with cervical cancer. We will review the current screening recommendations for cervical cancer as well as the diagnosis of cervical dysplasia and cervical cancer, including its staging. At the end, we're going to be finishing up with a practice question. Let's start with a clinical scenario. This question I obtained from the Julian Ong Prologue self-assessment book. You have a 38-year-old multifarious woman that comes to your office with vaginal bleeding. She is currently 16 weeks pregnant. She is found to have a 3-centimeter friable mass confined to the cervix. She undergoes a cervical biopsy, which reveals an invasive squamous cell carcinoma of the cervix. Clinical staging and metastatic workup confirmed tumor confined to the cervix. After extensive discussion of management options, the patient states that she has no desire to continue the pregnancy and requests definitive oncologic management. Which is the most appropriate management for this patient? Option A includes cesarean delivery, radical hysterectomy, and pelvic lymphadenectomy after documenting fetal lung maturity. B. Pelvic irradiation with fetus in situ. C. Neoadjuvant chemotherapy, then radical hysterectomy and pelvic lymphadenectomy. D. Radical hysterectomy with pelvic lymphadenectomy and fetus in situ. We are going to continue the rest of the presentation and then we'll come back to answer this question. In comparison to other GYN cancers, cervical cancer starts developing in younger populations. Thus, screening for neoplasia starts at an earlier age. In 2019, cervical cancer estimates included over 500,000 new cases and over 300,000 deaths worldwide. In the United States, women have 1 in 132 lifetime risk of developing cervical cancer. In 2019, the American Cancer Society estimated approximately over 13,000 new cases, as well as over 4,000 deaths from cervical cancer. In terms of pregnancy, cervical cancer complicates approximately 1 in 1,200 pregnancies. The diagnosis of cervical dysplasia in pregnancy may occur in up to 5% in some populations. Because the peak incidence of CIN and childbearing occurs in the 3rd decade of life, it is important to remember that cervical cancer screening is an important component of prenatal care. Risks associated with cervical cancer include lack of regular cervical cancer screening, HPV infection, as this is the primary infectious agent associated with cervical cancer, lower socioeconomic status, lower educational attainment, older age, obesity, smoking, both active and passive, increasing parity, higher number of lifetime sexual partners, patients with immunosuppression, such as patients with AIDS or transplant recipients, or other patients who are in immunosuppressive therapies. As you know, these are the screening recommendations for cervical cancer. This is the chart by USPSTF. Screening starts at age 21, and it is recommended from ages 21 to 29 that patients have cytology every 3 years. From ages 30 to 65, patients should undergo co-testing with HPV testing as well as cytology every 5 years. For patients that have had normal screening throughout their lifetime, they can stop screening at age 65. Obviously, this changes for patients that have had a history of cervical dysplasia. Let's do a quick review of the cervical cytology result terminology. It is most often used in the Bethesda classification system. And so for normal results without evidence of cellular changes, it is termed negative for intraepithelial lesion or malignancy. If there are cellular changes noted, there can be either squamous cell or granular cell changes. So for squamous cells, there is atypical squamous cells, low-grade changes, high-grade changes, or evidence of squamous cell carcinoma features. For glandular cells, there can be atypical endocervical cells, endometrial cells, or glandular cells, or evidence of adenocarcinoma. This image portrays the histologic findings of the cells of the cervix. So in terms of abnormalities at the squamous cells, we use the cervical intraepithelial neoplasia classification. So as you can see from the first image, we have a normal appearing full thickness of the cervix. So you have the basement membrane, you have the basal cells, and then you have the squamous cells. As you can see in CIN1, there are abnormalities with the basal cells, and this includes the first 1/3 of the squamous cells. In CIN2, you have involvement of 2/3, and then in CIN3, you have full thickness involvement. Now, when there is invasion into that basement membrane, that is considered squamous cell carcinoma. So you obtain the pap smear on your pregnant patient and it came back abnormal. What is the next step? So really the recommendation by the American Society for Colposcopy and Cervical Pathology is similar to those patients that are not pregnant. So for those patients that have an immediate risk of CIN3 equal or greater than 4%, colposcopy is recommended. Really the goal of colposcopy in pregnancy is to rule out cancer. In areas that are noted to be dysplastic or abnormal, the ASCCP does recommend that you obtain biopsies. Now, given the higher risk of bleeding in pregnancy, random or non-directed biopsies should be avoided, as well as it is important to consider that in later trimesters, such as the third trimester in compared to the first, the risk of bleeding is much higher. Endocervical curettage should be avoided in pregnancy. The ASCCP does recommend that patients that are diagnosed with a high-grade lesion, such as CIN2 or 3, or adenocarcinoma in situ, should undergo surveillance via colposcopy or co-testing every 12 to 24 weeks during the pregnancy. The choice of surveillance is individualized based on the patient, as well as the gestational age, the level of experience of the colposcopy. Carcinoma in situ is diagnosed, it is recommended that a referral to a gynecology oncologist is made. For patients that desire to proceed with further repeat colposcopies or further repeat biopsies postpartum, that is also reasonable. It is recommended that it's not done sooner than 4 weeks postpartum to allow time for the cervix to heal. This image includes a recommendation from the ASCCP 2012 guidelines for recommendations for cervical cancer screening as well as management of dysplasia results. You can refer back to it if you find that it's helpful, and I obtained this image from the paper listed below. What about conization procedures in pregnancy? So really for this, you have to discuss the risks of the procedure versus the benefits, which would be obtaining a diagnosis of microinvasive carcinoma that otherwise would remain undetected. Conization procedures are only indicated when cancer is suspected, and really the goal of this is not to do a complete excision of the transformation zone and removal of the abnormal cells, but rather the goal is to determine if there is deeply invasive cancer. The recommendation, as you can see from the picture, is to do what's called a shallow cone rather than your normal cone biopsy. The most common maternal risk is hemorrhage, either immediate or delayed, and this can occur in up to 14% of cases. This risk is higher in the third trimester. Overall, cone biopsies in pregnancy are associated with a 3 to 6% risk of perinatal death as a consequence from profuse hemorrhage or delivery from a periviable or extremely premature fetus through an incompetent cervix. This is a table outlining the different histologic subtypes of cervical cancer, and we won't be going into too much detail, but the important things to note is that squamous cell tumors predominate, and they make up to 70% of all cervical cancers. They arise from the squamous cells from the ectocervix. Adenocarcinomas make up to 25% of cervical cancers, and they arise from those endocervical columnar cells. So in terms of the next steps, if you have pathology that's concerning for cervical cancer, of course you want to do further workup. So you can do further imaging through MRI as well as cystoscopy, bructoscopy. This includes the FIGO staging of cervical cancer, and we're going to do a quick summary. This is a table I obtained from Williams' gynecology book that outlines all the different stages. We are going to be doing a quick summary of them, but you can refer back to this table to study more in depth the different subsets of the staging. Zero is carcinoma in situ, or that cancer that is only confined to the squamous cell layer without involvement of the basement membrane. Stage 1 carcinoma is strictly confined to the cervix and can be subsequently subdivided into 1A or 1B. Stage 2 is carcinoma that has extended beyond the uterus, but has not yet extended to the pelvic wall. It can involve the vagina, but does not go as far as the lower third of the vagina. 3 carcinoma is cancer that has extended to the pelvic wall. Tumor can involve the lower third of the vagina and can also involve the pelvic or para-aortic lymph nodes. 4 carcinoma involves more distant metastases. It can include extension beyond the true pelvis, as well as involvement of the mucosa of the bladder or the rectum and spread into distant organs. Cancer treatment in pregnancy can be very difficult, and it is important to discuss with the patient what their wishes are, whether they wish to prioritize treatment, and whether they desire to continue the pregnancy. If they desire to continue the pregnancy and desire further treatment, it is important to have that discussion as how this can impact the fetus. This is an image that I obtained from the prologue assessment book, and the primary literature is cited in the bottom. And so the recommendation includes for patients that do not desire to continue the pregnancy in stages 1B to 2A, you can do a radical hysterectomy and pelvic lymphadenectomy with the fetus in situ. For more extensive disease in patients with 2B to 4A, you can do radiation therapy as well as chemotherapy. This will likely result in spontaneous abortion of the fetus. For patients that desire to continue with the pregnancy, you can consider neoadjuvant chemotherapy based on the stage that the patient is. Once they have reached fetal lung maturity, you can consider delivery. The recommendation is to do a classical cesarean delivery to preserve the lower uterine segment. It is important to note that if you are doing chemotherapy, weeks 5 to 10 of gestational age have a higher risk of impact by teratogens, as well as neonates who are exposed to chemotherapy. It is important to monitor them for bone marrow suppression, as well as following up their neurodevelopment. All right, so with all of that, let's go back to our case. So things that are important to note is that the patient is currently 16 weeks. She has a tumor that is confined to the cervix, meaning that she is stage 1, that we know. And she has no desire to continue the pregnancy. So in terms of the treatment options, so A would be for a patient that desires to continue the pregnancy. B would be more appropriate for a patient that has extensive disease. Really, the best option for this patient would be option D, radical hysterectomy with pelvic lymphadenectomy and fetus in situ. I hope you found this review helpful, and good luck on the CREOGs.